cambiar vidas,
change lives,
change organizations,
change
दुनिया में
organizations,
बदलाव.
change the world.
Welcome, everyone. Those of you at the end want any more information, you go to my website, robertpearlmd.com, and I'd love to hear your thoughts if you read my new book, ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine. And it is already a #1 bestseller on Amazon's new book list. And all profits from the book go to Doctors Without Borders. And I should say at the beginning that I have no financial relationships with any of the companies that I'll be talking about today. I just bringing today the kind of information that I do teach in my course at Stanford. So let me start with a question to you. If I could tell you with 90% certainty that 5 years from now, your car, or everyone's car, would go as fast as an automobile, and 10 years from now, as fast as a rocket ship, would you do anything different today? Would you just wait 5 or 10 years, see what's going to happen? Would you focus on the 10 or 15 or 20% possibility that it won't happen? Or would you be preparing yourself for what is a most likely, and I will say almost inevitable, outcome? And that's where we are right now when it comes to generative AI. I call the book ChatGPT MD because the letters flow together nicely, GPT, MD, 5 letters sitting there. And also because it helps understand what generative AI does, and we'll talk about that in a few minutes. But generative AI itself is doubling every year. You may remember Moore's Law on computers, doubling in power every 2 years. This is doubling every year. In fact, actually probably closer to 6 to every 9 months. And that means that after 5 years, it's going to be 32 times more powerful than today. So I ask you not to think about what exists right now, although what exists right now is pretty remarkable, but what's going to exist in 3 to 5 years. And that's the time frame that we are looking at. The human mind has great difficulty, though, understanding exponential. We do very well when it comes to arithmetic growth or geometric growth. You may remember back in COVID, we had an exponential virus. And we said that if you had a lily pond with a green plant on it that would replicate every night, and it would take 50 days to cover this pond completely in green, what would it look like on day 43? On day 43, 1% of that pond is covered. You'd say, Robbie, you're all wrong. This is never going to happen. Look, we're 43 days in and it's 1% covered. That's the nature of exponential growth. Even on day 48, it's only a quarter covered. Day 49, it's still only half covered. And only at the end do you see the full impact of that. And I believe that that's what's going to happen in generative AI, and no field will be more impacted. Every field will be impacted, but none will be more impacted than medicine. And the reason for that is that the exponential growth in generative AI comes from the data that is submitted to it, the pre-training around it. One of the great concerns when it comes to generative AI overall is that we're running out of internet. They've downloaded almost all of the information available into the application. But in medicine, of course, we have so much more. We have meetings that are going on constantly. We have a doubling of medical information every 72 days. And we have a remarkable untapped resource that I'll talk about, which is that every patient sitting in a hospital, a lot of patients sitting at home are sitting on monitors, producing constant data. Almost every procedure that we now do, whether it's an operative robot in the surgical suite or whether it's a catheterization to unblock a coronary artery, the procedural suite, we have the data information coming off of that and can use that for learning. When I think about exponential growth, I think about the introduction of the iPhone, 2007. I got a phone call from my dad. And my dad said, Robbie, I just bought an iPhone. He knew I was interested in technology. And I said, Dad, that's great. What are you going to do with your iPhone? And he said, I'm going to lock it in the trunk of my car. So if I'm in a car wreck, I can take it out and get help. What else would you do with an iPhone? That is the mindset that sat there in 2007 And I think that same mindset is sitting in generative AI today. And so I'd like to at least gaze into the future along with you. And by the future, again, I mean 3 to 5 years. I don't mean 20, 30 years, as we often do when we talk about technology. The American healthcare system needs it. It's badly broken. It's a 19th century cottage industry. It's fragmented. You have doctors and hospitals scattered across communities. Even in the same hospital system, they can't exchange information. They can't collaborate and coordinate the way that they should. They're paid on a piecemeal basis. We call it fee for service. The more you do, the more you get paid. Whether it's any good doesn't make any difference. In fact, if you have a complication, you're often paid twice. The technology we use is pretty outdated. The most common way that clinicians exchange vital medical information, the fax machine, an 1834 invention. When I tell my students in the Stanford Graduate School of Business about the fax machine, they don't even know what I'm talking about. They've never seen a fax machine. And that's how what we think of as the most modern medicine in the world is provided to patients. And there is no leadership structure. Change can't happen. Of course, there's CEOs of every individual slice of that world, but it's not possible to make the large changes all that might happen. In 2015, I looked at the same problem and came to the same conclusion about the challenges that existed. I wrote a book called Mistreated: Why We Think We're Getting Good Healthcare While Usually Wrong. It begins with the story of my dad, who died from a preventable medical error. And I said, it's these 4 things. Let's just change the structure, the financing, the technology, and the leadership. And look how much better we could do. 3 years later, I looked and nothing was any different. So I researched it. And that's what you do when you teach in the business school. You ask the question, why is something that seems so logical doesn't happen? There has to be an answer, so you research it. And I came to the conclusion it had to be the culture of medicine. Wrote the book Uncaring: How the Culture of Medicine Kills Doctors and Patients. You know, there are professors at Stanford who say that culture eats strategy for lunch. We could debate that extensively, but I thought I'd maybe found the answer. And again, 3 years later, nothing had happened. And again, I said, why? What is standing in the way of making this change from fragmentation to integration, from a transactional fee-for-service methodology to one that is capitated, that rewards people for keeping people healthy, preventing complications? And I came to the conclusion that people didn't have the tool necessary to be able to accept the risk intrinsic in a capitated form of medical care. And then all of a sudden, OpenAI releases ChatGPT. And ChatGPT is now a tool. And generative AI overall, it can be Gemini from Google, or it can be Claude as another potential source of information. And now we had the ability to predictably be able to achieve higher quality, easy convenience, and lower cost. But I like to think about it, we actually can lower the cost of medicine by raising quality and improving access, something that was not possible before, that we'll talk about in a couple of minutes. Before I go there, though, I want to talk about the fact that we use the word AI as though all AI is interchangeable, and it's not. 3 distinct forms, completely different from each other. All they share are the 2 letters, A and I. The first one, very popular, actually began in Stanford, 1980s. It was used to diagnose infectious disease and prescribe antibiotics. And it uses what's called rules-based. The rules-based approach has a clinician, an expert, or a set of clinicians put in data about how to make decisions. Sometimes it follows an algorithm. You have a cough, and you ask, do you have a fever or not? If you have a fever, you want to know if the sputum is discolored or clear. And you go down an algorithmic tree, and that provides a diagnosis and an answer. And once you know your diagnosis and answer, then you can upload it with information about the most appropriate antibiotics for that particular infectious agent. The challenge with a rules-based is that the rules we learn in medical school, the heuristics, the rules of thumb, 4 or 5 different ways to be able to decide whether something is cancer. If there's a a lot of nuclei and division, a lot of cells in division if the nuclei are abnormally shaped. If the cells are invading rather than pushing tissue, we call it cancer. But it's 4 or 5 rules of thumb, and they're not sufficient. And so therefore, intuition becomes a very powerful tool. So no rules-based AI is going to be as good as the clinicians who did it. And that was the experience. It was still reliable. It was still good. It just didn't make any major impact in healthcare. Come 2000, programmers start to use a biological approach. They start to use neural networks, deep learning. And now we're going to move into what's called narrow AI. And many of you are very familiar with narrow AI. You take 10,000 mammograms, 5,000 of which show cancer, 5,000 of which are either normal or have benign disease. And the algorithm and the tool, the narrow-based AI finds 10, 20, 50, 60, 100 different slight variations in these 2 data sets. And it assigns probability to each factor. And it's now not reliant on 4 or 5 heuristic, 4 or 5 rules of thumb, but no, 60, 70 different minor variations that it can easily spot between normal and abnormal films. And now it becomes better. The data says it's about 10% better than radiologists at reading mammograms or complex chest x-rays. Extremely good. There's 600 of these approved by the FDA. What's the problem with a narrow AI tool? It's narrow. A tool designed for mammograms can't read chest x-rays, can't read brain scans. You need tens of thousands of these. They're very expensive to create. And so far, again, very little penetration into medicine. The second problem with a narrow-based tool is it's dependent upon the rule set. When Watson came out, as you may remember, there was a tremendous enthusiasm about the tool. It's a narrow AI tool. I was skeptical. And I was skeptical not because of the technology. The technology is superb. I was skeptical because the data upon which it is built, which is the electronic health record, is far from exact. 2 patients, both of whom say they have severe pain, one can objectively have a 3 and one can objectively have a 7. How we sort data, how much we copy and paste. And the problem with the narrow AI tool is that a slight problem in the data set produces a tremendous problem in the outcome and recommendations. So these tools are very good for things like for visual, for mammograms, for chest x-rays, for retinal scans, for melanoma detection. But they don't do a good job when it comes to establishing a diagnosis. And now we come to generative AI, totally different. Generative AI starts, we call it GPT, it's really PTG. The P is pre-training. All the information available on the internet, every medical textbook, every journal article is downloaded into the system before it is utilized. This is the way actually you learn as a medical student, right? You get the textbooks in internal medicine and in surgery and in psychiatry, and you read those, and then you read some journal articles as you do your clinical rotations, except that it's done all of that. And now with the totality of knowledge, it has to be transformed. These are parameters, billions of them. Newer articles are more significant than older articles. Articles from peer-reviewed journals are more significant than ones from non-peer-reviewed journals. Ones out of Stanford or the Mayo Clinic are more valuable than ones coming out of individual clinicians. And with that, you go to the G. It can generate an answer to any problem. Since I published ChatGPT MD, I've done 54 podcasts. And in one of them, the host said, at the end, this was off the air, Dr. Pearl, you're a skier and you're a doctor. My husband fell skiing about 2 months ago. He slid about 100 feet down the hill with his arm over his head, and his shoulder just still hurts. And he can't use that side as well as he does the other side. What's going on? And I said, I am a skier. I know a lot of ski injuries. I think I know exactly what he has. But I want to ask you something. You said on the podcast today you'd never use ChatGPT. I want you to get the free version. Don't even spend the $20 a month, a latte a week for GPT-4. Get the free version and put every piece of information you just told me and as much as you can about the limitations that he has into the application and see what it says. 5 days later, she contacted me. She said, thank you so much. First of all, it said what he most likely has is a rotator cuff injury, a rotator cuff tear. He said he needs an MRI, and you should see an orthopedic surgeon because he most likely needs surgery to fix the problem. Now, think about that. Compare that to if she had gone to Google and clicked on shoulder pain or limitations in arm function. She would have had a tremendous amount of information, but not a lot of expertise. She could have had 200 diagnoses for shoulder pains. She could have had a listing of the most common reasons why people have shoulder pain or have problems using their arm, but she would not have had it specific to her husband's problem. That is what a generative AI tool can do. And by the way, it does it quite well. Some of you may have seen that between the first version of a generative AI tool that was publicly available, past the step 2 examination, the one we all take at the end of medical school, the licensing requirement for doctors, with a passing score, not very differentiated from everyone else. Half a year later, it was in the top 10%. I'm sure today it's in the top 1%. They gave the information to chief residents at Harvard, and they compared it to the ChatGPT. ChatGPT was better at diagnosing complex medical problems. These weren't the easy ones. I saw a couple of ED docs. They had a study in JAMA where they took patients who were coming in and gave the diagnosis and all the findings to ED board certified physicians as well as the generative AI tool. And the doctors were about 85% accurate. The generative AI tool over 90%. They looked at communications from patients that were done electronically, emails, and they had them evaluated. They took the ones that were available from clinicians, the ones that were done by generative AI, that are evaluated by people who did not know which one they came from. And these were both clinicians and patients. And the people valued in terms of accuracy and completeness, the generative AI tools 4 times more than the physicians and 9 times more on the basis of empathy. We are looking at very powerful tools today, and we are only looking at the first generation, a generation that's not yet ready to do some of the things that I'm going to be telling you about, but will be when it becomes 32 times more powerful in a mere 5 years time period. Let's look at some of the applications for what this technology can do. When I look at the question of why do we have a medical system that is problematic, expensive, we spend $13,500 per American today. By the way, other countries spend about half. We know that life expectancy today is no better than it was in 2010. We know that 400,000 people die annually from misdiagnoses. Another 400,000 people are permanently disabled as a consequence of a misdiagnosis. In the New England Journal of Medicine, they did a study on patients who either died in a hospital or were transferred from the medical unit to the ICU. 1 in 4 of them was based upon a misdiagnosis. 250,000 people, including my dad, died from medical errors. And if you look at how well we do at managing chronic disease, it is poor. I'll come to that in 1 second. 60% of physicians are burned out. 70% of patients are dissatisfied with the system of medicine. Over half of Americans can't afford care. The list goes on and on and on. And what clinicians do when they have a series of severe symptoms, they try to make a diagnosis. And in this case, I think the diagnosis is the crisis in chronic disease. If you ask why are physicians so burned out today, I think that we've given them a job they can't do. There are just too many problems. It's been estimated that to do proper management of chronic disease, and chronic disease, by the way, I mean hypertension, diabetes, asthma, heart failure. When you ask people to do this and you look at all the things that we recommend that they would have to do for a panel of patients, it would take 27 hours every day. It's not possible. The result of that is people having to just run faster and faster and cut corners. At the end of the day, they go home knowing they could have done a better job. They just didn't have the time. It's not lack of knowledge. It's not motivation. It's not dedication. It's simply a matter of time. And why is that? Because it just takes much longer to take care of a patient with chronic disease than acute disease. A patient comes in with right lower quadrant pain, you diagnose appendicitis, you take out the appendix, you are done. Someone comes in with diabetes, you're going to see them 4 times a year for the rest of their life. You've just signed up for 100 or 200 medical office visits. Chronic disease, I believe, is the problem. We know that we do a poor job of preventing chronic disease. The epidemic of chronic disease is growing. We know that 1 in 3 Americans today either have diabetes or pre-diabetes. And when you start to look at how well do we manage chronic disease, we take something like hypertension. Now, when I was the CEO in Kaiser Permanente, we did a pretty good job. We were over 90% effective control of hypertension. Hypertension, for those of you who are not in medicine, it's the #1 cause of strokes, 40% of strokes. If you can eliminate hypertension, you can eliminate 40% of strokes. Major contributor to kidney failure, major contributor to heart disease. So we were over 90%, but across the nation today, it's 55 to 60%. Those of you at Stanford may remember that we have a tremendous engineering school. And the engineers have produced Band-Aid size monitors that can monitor blood pressure, pulse, temperature, blood sugar, blood glucose. We can monitor the biologic, physiologic functions with extreme accuracy. These tools are 99+% accurate. And I challenge the clinicians on this call to give me an example of us using these wearable monitors in your practice today or in the practice that you know about in your local community. We don't use very reliable monitors. Why? Because we don't know what to do with the data. You diagnose hypertension, you start someone on a medication, you give them a monitor. 3 times a day, they're going to have their blood pressure checked. At the end of the month, they'll have 100 readings. 90 are normal, 10 are abnormal. How are they doing? Well, 90 are normal. We're doing great. Well, 10 are abnormal. We're doing terribly. What is going on? That is the challenge that exists. And clinicians don't want 100 blood pressure readings. And clinicians don't want to have the information clogging up their electronic health record. So we have very powerful technology, tremendous reliability and accuracy, an ability to be able to change practice, and we don't do anything with it. Generative AI changes that. A decade ago, I talked with the CEO in Apple, and I said, you know, you're bringing out the Apple Watch. You're able to do things like monitor AFib. Why don't you build in an AI tool capable of telling people who are having AFib how they're doing, so that when they're having a problem, they can contact their clinician and be able to get immediate intervention rather than waiting 3 or 4 months for the follow-up visit? And I didn't get a satisfactory answer because I already knew the answer. It's the liability. Generative AI changes that. It will now tell you after 1 month how you're doing. And again, I don't want to get too technical on this conference today, but it's called GPTs. You can actually use a GPT to be able to download the clinician's expectations about what is going to happen. And the tool can use those expectations, look at the various trajectories, do a data analysis, and say, after 1 month, you haven't responded. Let the clinician know and make a change in medication at 1 month, not at 4 months or 6 months, whenever the follow-up was scheduled. And by the way, at the follow-up, what are you going to have? 1 blood pressure reading. And if it's high, they're going to say it's the white coat syndrome. And if it's not high, maybe it just was not high at that time, but it was high the day before, the day after. You're now starting to have an ability to monitor. And if you can move from 55% to 90%, all of a sudden you've eliminated 20% of strokes. You've improved kidney failure. You've improved heart disease. Diabetes. We already said a third of Americans have diabetes. How well do you think we manage diabetes? 30% control in the United States today. This is the leading cause of kidney failure. 80% of lower limb amputations are from diabetes. Blindness from retinal disease secondary to diabetes. Cardiovascular problems. The complications, well, chronic diseases are rampant. 60% of Americans have at least one chronic disease. 75% of people on Medicare have two or more. And they account for 70 to 90% of medical costs. And they produce heart attacks, strokes, kidney failure, cancer, lower limb amputation. I want you to think for a second. If we could, and by the way, the CDC data is what we refer to. The CDC has said that if we could effectively manage chronic disease, and by that they don't mean perfectly, they mean effectively with the tools and understanding that exist today, we could eliminate 30 to 50% of heart attacks, strokes, cancers, kidney failures, lower limb amputation. What would that do to the American healthcare system? What would happen to quality, to life expectancy? And on the reverse side, what would happen to cost? 30 to 50% fewer heart attacks and strokes and significant cancers and kidney failure. 7% of Medicare is for renal dialysis. Cut that in half. You've lowered Medicare costs by 3%. The opportunities are massive. And that is what generative AI does, because it will allow you to know what is going on. It doesn't just provide knowledge to the patient, it provides expertise. Another example, the acute disease. It's 11:30 at night, your kid spikes a fever to 102.5. What do? Do you come to the ER where you know you'll probably have an hour wait surrounded by people coughing with infectious disease? Or do you stay at home? Well, you Google it up and you see, well, maybe it's meningitis. My child might not be alive in the morning. You call your doctor's office. What does the doctor's office say? Go to the ER. Why does it say go to the ER? Not because that's where you should go, but because that protects the clinicians. You call the answering service. What do you get? The doctor will call you back in the morning. You don't want to know in the morning. You need to know now. Generative AI can ask the questions. Is the child lying in bed limp? Flaccid? Is the child riding the bicycle around the living room? That's going to lead to two different outcomes. And with that, it can provide expertise around that decision process. It empowers patients, and should it identify a potentially life-threatening problem, you can have assistance through telemedicine, calling to the ER, sending the ambulance, being able to provide the care immediately. What do we have today? We don't know. It's all a guess. Is the application perfect? Probably not. But is it far better than what exists today? Absolutely. A third example to me is the hospital at home. Probably 30% of the people in the hospitals, by the way, account for over 30% of healthcare costs in the United States today. Probably a third of the people there don't need to be in the hospital. They can be managed at home, assuming they have a supportive family. But why don't we do that? The answer is because although most of them will do just fine, a small percentage, 2 in 100, some number like that, 3 in 100, will actually have a more severe problem or will deteriorate across the night. And we want to have them observed and monitored. Today at home, you can't do that. Generative AI combined with wearables, combined with monitors, can allow that to occur. And it will identify problems sooner, often sooner than in the hospital, which is a fourth application, which is that if you're in the hospital on a medical surgical unit, and this research was done out of Kaiser Permanente in the research division, what we know is that some of those patients, again, a small percentage, are going to deteriorate across the night, need ICU admission. Some of them are going to die. But even the ones admitted to the ICU, once they suffer that complication, their chances of dying over the next month are 4 times higher after they go home and theoretically recover. Again, a generative AI tool using data inputted from now in this case, the bedside monitors. Obviously, if you're in the ICU or in teleservice, you're being monitored by nurses. But what happens? The nurse comes around at 8 a.m. or at 8 p.m. and then doesn't come back for 4 hours. What happens in that time period? We have no idea. We have no idea between doctor's office visits. We have no idea between nurses being able to check on you. We have these gaps. And if we have more information, we can better manage the chronic diseases and prevent the acute exacerbations and problems. When you start looking out 10 years, however, you're looking at an even more advanced system. You're looking at the ability to be able to avoid hospital-acquired infections and preventable medical errors. We know how to do that. We know that there are hospitals that are able to eliminate central line infections because they follow pretty simple protocols developed by researchers at Johns Hopkins. We just don't do it all the time. We know that nurses can avoid medication errors if they follow certain protocols. We just don't do it. A technology using video can observe what's going on and be able to remind people about the changes that need to happen. And if you look out 10 years, what you're going to see is that all the procedures that we do today, as I say, increasingly we don't touch the patient. We're using a robot, we're using a catheter. We touch the patient's groin to pass the catheter, but the real action is happening up the coronary arteries, several feet away up in the chest. It's done off of a monitor with a response, either a lever that's pulled or a catheter that's advanced or pulled back or dye that's injected. Those are the only things that we can do at the distance that we work. These technologies are called large language models. It's what allows you using them to paint like a Rembrandt because it can predict the next stroke. It allows you to be able to program a computer the way a IT trained person might. It allows you to program and write songs like Drake would because it can predict that next note. It's going to be just as good at predicting the next maneuver the surgeon or the interventional radiologist would have done, the cardiologist would have done. This opportunity to have expertise is embedded in the tools themselves. Before we can get there, we do need to be able to address some of the challenges of today. GPT-4 reduced hallucinations by 83%, but they still exist. 5 will reduce it a lot more. By the time we're at 6 and 7, they're going to be almost very rare, if at all. We need to deal with issues of privacy and security, bias, misinformation. There are a lot of problems. One of the pieces I believe very strongly is that we should not be comparing this technology against perfection. We should compare it to what exists today. Is it more dangerous to go to Google and click on a problem when it comes to privacy, when it comes to bias, when it comes to misinformation? And again, if you have the chance to read the book ChatGPT MD, I explore in great detail, while actually it's less. It's not that it's zero. It's just less than exists today. If 400,000 people are dying from misdiagnoses, would this technology make it 800,000 or 200,000? Would it be able to make those improvements and reduce medical errors in half, or would it increase medical errors? Would it allow us to take chronic diseases and the complications from hypertension, from heart failure, from diabetes, and would it increase it or reduce it? And when you start to look at that, what you start to realize that we can save hundreds of thousands of lives every year and lower cost if we accomplished it. But here's the biggest piece, the biggest problem that I see, which is people. And that is that any technology that slows doctors down or erodes their income will not be used. It's just the reality. We use the electronic health record with no problem. I can't find very many people who like it at all. Why is that? Because it slows doctors down. We have tremendous opportunities with the internet, even with telemedicine, and we don't use it very often today. Why is that? Because it compromises income. I don't say those things negatively. They're just the realities that exist. And so if we're going to use a tool that's going to empower patients, a tool that's going to reduce heart attacks and strokes and cancers and peripheral and heart and kidney failure and peripheral amputations, if we're going to have a tool that's going to be able, and I think it will, to do 20 or 30% of what clinicians do it at home, and doctors can't bill for it, can't charge for it, can't benefit from it, it's not going to happen. And here's the opportunity. The opportunity is to move to capitation. Because if you move to a capitated system, I don't mean individual physicians, I don't mean at the insurance level like it is today, but if groups of doctors come together and they're willing to accept the risk of managing a population with a fixed fee, being paid the amount of money today, but then when they reduce heart attacks and strokes and cancers, being able to benefit financially as a result of that. When there are no medical errors, being able to benefit financially as a consequence of that, they are going to do those things with a tremendous intensity. They are going to use this technology. They're going to encourage patients to do it. They're going to be willing to respond at 1 month, changing medication rather than waiting to 4 months, because they know they're not going to get 100 blood pressure readings into their EHR. They're going to get reliable information out of a generative AI tool. But making that change is not going to be easy. And so I'll close my comments by offering you my thoughts on how leaders make difficult things happen. And that is a model that I do teach, which is the A to G model, which is that there are a lot of steps that have to happen. Simply mandating it simply because it's a great idea. Great ideas go nowhere without leadership in healthcare today. I use A to G because it's an easy mnemonic to remember. A is the aspirational vision. What you're asking people to do, it has to touch their heart. It has to be inspirational, but it also has to be realistic. If it's inspirational but not realistic, it's a dream. If it's realistic but not inspirational, it's work. The combination. Martin Luther King was brilliant at aspirational visions. He didn't tell you he could eliminate the prejudice and the hatred inside people's hearts. He told you that one day on the hills, you would see the children of slaves, the children of slave owners dancing, holding hands. And it exists today on the soccer fields and on the baseball fields across the nation on Saturday mornings as people and children play together. The B is behaviors. You got to be very specific. If doctors think that you're asking them to spend an hour with every patient, teaching them how to use ChatGPT, teaching them how to enter data and understand what to do, they're not going to do it. It's too much time. They don't have that time. So you've got to put in place educational programs, create videos, have learning tools that they can be able to use, opportunities to have the people trained and have technological assistance available to use GPTs to download the common expectations of each clinician when they prescribe a blood pressure medication or when they prescribe insulin to a patient. You need to see context. People have to understand what's going on. I mean, people on this conference today have a tremendous amount of educational opportunities and information, but the typical American doesn't have that. And so we have to provide the context for the other clinicians who don't have that opportunity to get that information about what's going on in the world. And I tell people, I want you to think about one statistic. According to the federal actuaries, by the year 2031, that's only 7 years from now, healthcare is going to increase $3 trillion a year. Do any of you believe that it actually can increase $3 trillion a year? Do you think that we could afford that as a nation? Do you think that Congress is going to vote to allow that to happen? I think the opposite's going to happen. We're going to see increasing pressure and ratcheting down of reimbursement. We already saw it this year, by the way, in Medicare. For the first time, Medicare has cut reimbursement, and Congress did not reverse that decision. We're going to see more and more of that going forward. So is it going to be problematic to make these changes, to accept capitation, to put in place a generative AI tool? Sure. But what is the alternative? And that's going to be to have to run faster and faster with more and more prior authorization and more restrictions on clinical practice. D is the data. How are we going to follow this? How are we going to tell how our patients are doing? And we need to be able to update people on a continual basis. And leaders have need to make people understand that when they put a data source in place that they're going to distribute broadly, and it fails to demonstrate that which they expect, what are they going to do next? If hypertension control stays at 55%, what are they going to do next? Because if they do nothing, the message is blood pressure is not important. And so they need to think about that in advance, and how are they going to make sure that it happens? And E is the engagement of the leaders. No one cares how much you know as a leader until they know how much you care. And unless the individuals are out there, we tend, when we're putting in place major change programs, to stay focused on our executive team, to stay in our offices, and exactly the opposite's necessary. We need to go out and interact with people because they're afraid. This is their livelihood. This is their profession. This is their income. They want to make sure that, we always say to tell them, work smarter, not harder, and then they end up working harder. We want to make sure that we are able to engage them at a personal level and have them have the trust and confidence they need. And as for the faculty, we're going to need different kinds of leaders in this kind of empowered world. People with a lot more technological expertise, a lot more patient empowerment, ability, and skill. We're going to need a governance, which is not just the formal and informal, it's also the incentives. Financial incentives always work, but they never produce what you expect. I remember an organization that decided to pay GI doctors a bonus every time they did an extra colonoscopy. And guess what happened? Instead of taking care of the unexpected polyps when they found them, they rescheduled a second colonoscopy. This is not going to be about incentives like we have today, an extra dollar every time we order a hemoglobin A1C. No, this is going to be measured by the clinical outcomes that exist. So in the end, what I think is that generative AI is going to be a tool that will radically change American medicine. It's going to create a triad of a doctor, a dedicated, skilled clinician, working with an empowered patient, using a generative AI tool, and the triad will provide better outcomes than any of the three alone. I can't tell you when exactly the change is going to happen, but what I can tell you for certain is that if it happens and you're not prepared, you'll be left behind and you'll regret it for the rest of your careers. With that, let me stop and take your questions for the last 15 minutes, if that's okay with the moderator.
Absolutely. But I will kick us off with something. We already see the political use of wearable data against users' consent. So how can we guarantee that our patients that this data is used solely for their benefit in precision medicine, rather than accessed by other parties and used against them?
I'm not exactly certain what people are talking about, because I know of data being used negatively in terms of insurance and denying care and things like that. I'm not sure there's anything specific about wearables versus all the other data that's available. There certainly are strict legal prohibitions about that, and they need to be enforced. But again, I go back to the whole notion of how is generative AI different, let's say, Google? And the answer is that generative AI is sitting, well, OpenAI has it. But remember, it's a subscription. It's not a advertising base. So there's no incentive for them to sell the data, because what they want are more subscribers. They're going to want to protect the data. It's sitting on your own application. And there were two recent things I think that probably are also very positive. The first one was the announcement this week by Apple that it was putting OpenAI's ChatGPT into Siri. And the thing about Siri is that Siri's information is sitting solely inside that iPhone. It's not sitting up in the cloud someplace where it can be accessed by someone else. And one of the big things that Apple has talked about is how do they gain the confidence and the trust of people. So I have a lot more confidence. I have a lot of confidence that they're going to do that more so than other companies that are dependent upon advertising. And one of the things that I'll point out is NVIDIA, which is the largest chip manufacturer along with Hippocratic, also announced a nurse AI bot, specifically with the data being restricted from being accessed by anyone else. And by the way, the cost of an hour, this bot is going to be able to answer questions about your doctor's recommendations, about your medications, about your symptoms at a cost of $9 an hour. I think what we're going to see is a rapid proliferation in the use of these tools by patients. I don't think we're going to have to be the intermediaries. I think the patients are going to want to be able to do that. And if you look at, again, one last thought is the OpenAI just released this week what's called GPT 4.0. And in this case, it was, for those of you who saw the movie Her, it sounds just like Scarlett Johansson's voice, the same kind of quick response, witty response. And I think what it's really designed to do is to appeal to a different demographic. If you look at the utilization of generative AI so far, you see that Gen Zs and millennials use it a lot. Gen X and baby boomers use it far less often. And I think a tool that you can just speak to as you would to your clinician, to a nurse, to a healthcare educator is going to be very, very powerful. So that's, again, why I talk about this evolution that's going to happen. I don't think that we can fully protect people any more than we can anytime anyone else uses the internet. But I don't see any reason why this technology won't be at least as good as what exists now. And I can make the argument it would be better.
Hi, Robert. I have a question which is slightly different. I wonder your thoughts on the potential of AI for mental health. So, building like an AI sort of chatbot, for example, to provide therapies to like patients like depression patients, because mental health issues are so prevalent, and we are really have not enough like therapists to cope with this issue. What are your thoughts on that?
I think that is a great question. I think there's tremendous possibility. I want to make a couple of caveats first. I think as soon as there's any concern about suicide, then the application has to stop. That is such a hard, intuitive decision to make. Those of you on the phone who are clinicians in psychiatry understand exactly why mistakes can be made. The second thing is that people with severe psychotic disease, again, is not going to be managed by a AI tool. But for the huge number of people who feel like they need to have mental health assistance, I think it's going to be a very powerful contributor, not to replace clinicians. I mean, this concern is that we're going to somehow replace doctors or nurses. We're not going to replace them. We're going to augment them. And what I mean by that is that because there is the shortage that you have talked about, that patients get seen and they get seen 2 weeks later, 3 weeks later. Why is that? What happens in between? And I think the tool is going to be able to utilize the information submitted by the clinician to then be able to provide that assistance and advice to the patient. And again, it's a large language model. As it gets trained by listening in on conversations, it's going to figure out the next question to ask. It's exactly the way that we train so many mental health professionals today. And so I think that it will be the piece that fits in there that allows people, and it'll have a broader application too, because as you're well aware, there's a lot of mental health issues today coming out of isolation. And it can be a tool to connect people together, to provide resources, to provide places they can go to engage with other individuals. So I think it'll be a very powerful tool. So far, what exists, there are tools that exist, and I call them good. But again, I'll go back to, if it's 30 times more powerful, they will be very, very good. And I think people will become increasingly reliant on them.
So pediatrician here, but I'm also currently in the health equity policy arena. And you touched very quickly on bias. And so, I think with the earlier versions, certainly a higher risk of bias because clearly bias in, bias out. But can you speak more of the risks of bias as it relates to generative AI? Thanks.
Sure. Yeah, no, this is an area of great interest and importance to me. In my book, Uncaring, I had a whole section on bias in medicine. And it's important, and why I started at the beginning differentiating narrow AI from generative AI is narrow AI is very biased. You may remember a few years back that Optum wanted to identify patients with chronic disease who are most likely going to deteriorate and be able to provide more resources to them. A really well thought through process. And so they put all the medical information come out of the medical record into the system. And they identified about 15% of patients would be African-American individuals, Black patients. And when researchers went back and looked at it, it should have been about 45%. Now, why did that happen? Because the application used as a measure of disease the dollars spent on care. That's logical, right? The more it costs, the sicker you must be. But what's the problem? Patients who are Black patients in the United States, get $1,800 less care with the same severity of disease. When COVID came around, we know that they were prescribed or offered COVID testing when the testing was in short supply, half as often as white patients with the same symptoms. We know from the New England Journal of Medicine study, they're offered sophisticated cardiac procedures less often. We go on the entire list. And what did the AI tool do? It just duplicated what happens in clinical medicine. It wasn't any worse, but it wasn't any better. That's why I'm optimistic about generative AI. Because generative AI has that ability to be able to, well, first of all, it's not only been trained on all of medicine, not just what doctors do, but what the textbooks say. It's also trained on bias. It's trained on recognizing that problems aren't there. And if you give it the prompt, one of the keys to generative AI is the prompt that you give. It takes about 10 hours to really learn how to become expert at it. And you give it the prompt that says, I would like to treat all my patients, including this one, in an unbiased way. It will prioritize the data and the information around bias to make sure that you're not. It's going to ask you, why did you prescribe 30% less pain medication to your Black patient than you did to your white patient? I think if you look inside why the mortality rate amongst Black women giving birth, the mother and child mortality rates are 9 times higher than any other nation, I think it's bias that sits in place. We know why women die. By the way, the majority of deaths occur after the delivery, not during the delivery. And they die because one of two things happen and they're not recognized. Either the woman bleeds or the woman has hypertension and has a major cardiovascular problem as a result of that. And the question is the nurse checking as often? Is the nurse going to be as concerned? Is the nurse going to contact the obstetrician as often for the same amount of bleeding? And I'm optimistic that if we use generative AI as an anti-bias tool, that we're going to be able to identify those things and lower the impact. Will we ever get away from bias in medicine? I don't think so. But can we do a far better job than today using generative AI? I'm optimistic that it's possible.
Thank you. AI is a technology that can be applied very broadly, could provide many aspects of healthcare. I would submit to you that looking through the lens of Clayton Christensen and the original work on disruption, that the most disruptive application would be in empowering patients and caregivers, which you referenced, that sustaining innovations will be all that other stuff, but a disruptive innovation would be empowering patients such that they could be co-pilots with their medical team. I'd be interested in getting your reactions to that thesis.
I concur 100%. I mean, that's why the book is subtitled about the AI empowerment of patients before doctors, by the way, in terms of the listing. I think it'll also help doctors avoid misdiagnoses and make other errors. But I think it'll be the patient who's empowered. It's exactly what I said. It's not knowledge about hypertension or diabetes or heart failure. It's the ability to have that expertise. I write in the book about an experience of a Harvard economic professor, a tenured physician, a tenured economist who was admitted to a local hospital, by which I mean a very famous academic hospital. And he knew that his problem was more severe than the doctors taking care of him thought it would be. They thought maybe it was going to be a gallstone or something, accounting for it. And he knew it was much more severe than that. And he put all of his data into ChatGPT and it said he had a 40% chance of having a ruptured appendix, and got them to order the appropriate CT study that was necessary to make the diagnosis. Because we know that human beings have cognitive biases, well demonstrated by Kahneman. And once we have a diagnosis, we tend to stick to it. We're not willing to say we might be wrong. So I think absolutely empowering patients will be radically different. I can't imagine another way to lower by 30 to 50% heart attack, strokes, kidney failure, all those problems you mentioned earlier, except by empaneling the patient. And really the question I'd throw back to you is, how likely are clinicians going to be willing to empower their patients? I think in many ways we've not done it because we haven't had the tools, because we've been afraid of 100-page stacks of Google links that were clicked on and printouts. And we were afraid of being overwhelmed even more than today. I think we need to shift that mind frame to say, is there 20 to 30% of what we do in our offices, in our ERs, in our hospitals that patients could do in their homes? And if we could do that, take 20 to 30% of that out, imagine what it would do to the flow of patients through the ER, patients for the getting care in a hospital, in the time we have with patients in our office. I think that generative AI, instead of eroding the doctor-patient relationship, will actually augment it, because it will give the clinician what is missing today, which is the precious thing called time. So, and they can go to robertpearlmd.com if they want any more information on any of these topics, or hopefully read the book. And if they do, I'd ask you to let me know what you think. Let me know if you agree or disagree. Let me know if you think I'm being too optimistic or too pessimistic. I think there's a lot of different ways to judge the future, as Yogi Berra said, very hard to do before it has yet come.
I'm wondering what you think it's going to take to get Medicare to ever approve paying for these services, certainly in consideration of fraud and given how we measure, RVUs and all of that kind of thing.
If you ask why are some technologies, of which you're talking about AI, which also we're going to be talking about telemedicine, not adequately reimbursed, the answer is very simple. In a fee-for-service world, people, whether it's the federal government who's paying or the businesses that are paying, they're afraid that all will happen is we'll do more of them. And then we'll do it more and more. That doesn't add a whole lot of value. It's why I'm such a believer in capitation. And as you know, Medicare has Medicare Advantage. Now, we can debate a lot about Medicare Advantage and a lot of things about upcoding and other things about it. But I think fundamentally, it should be a capitated system. The big problem today is that it's paid at the insurance level. It needs to be paid at the delivery system level. It needs to be paid to the clinicians providing that care. And then at that point, the deciding people are not Medicare or the insurance company. The deciding people are the clinicians doing the work. And I think that when they look at generative AI, they're going to see that they have the tool. Empowering the patient is what's going to allow them to be very successful, because it will improve their health. It will diminish the chronic disease. It will allow patients to know when they should contact the clinician and when they don't have to. It will allow patients to know when they need to see the clinician and when they don't have to, when they need to go to the ER and when they don't need to. All the things that are done today. But I don't think it's going to happen until we capitate it. So actually, I have less concern at the federal level, because there it's capitated. But it's capitated so far at the insurance level because clinicians have not come together to do it, with a very few exceptions like the Permanente Medical Group, or, by the way, ChenMed, which is a primary care only organization that does this, takes 100% capitation risk and achieves remarkable outcomes. And by the way, sees their patients with chronic disease once a month, not 3 times a year, because they know that managing chronic disease is the way you succeed in a capitated environment.
Curious as to who is leading in the MCI dementia space. And then the other thing is we're at an age now, we're 70 something. I'm having to make major decisions, and the problem is expectations. Since I heard about AI, I figured it was going to help kind of set general expectations, because nowadays people say it's just too complex for you to make decisions. I'm having to make major decisions, that I used to make when I was younger?
I think that the tool is going to be used by everyone who has the willingness to experiment around it. The tool is going to allow us to personalize all those decisions that you're discussing. You can put in place all of your medical information, all your laboratory results, or your genetic information. You can put as much detail about your family history. The more information you put into the tool, the better it's going to do, the more it can be personalized. And I think that right now, the tool is not yet where it needs to be. That's a lot of why I wanted to host this or participate in this webinar, because it's like flipping a switch. Right now, we know the need and we don't yet have the application. But when the application comes and we have the need, we still have to have the ability. And it's that way to move forward. And so I can't give you a specific place that people are leading. I can just tell you that there are a lot of people experimenting. And I think that the more significant utilization for those kind of difficult individual decisions is going to be common come certainly 10 years from now, and more likely by 5.
Thank you so much.
Thanks so much for staying on. I really enjoyed your talk, and I think I completely believe what you were saying about the positive potential benefits of generative AI on augmenting the patient-physician, the patient-provider relationship. But one of my questions, when you talk about capitation right now, when you look at taking on both the cost as well as the benefit of generative AI. Currently, the way our fee-for-service system and even a capitation system puts all the burden of the cost upon the clinicians, upon the providers, right? Like when legally with the HITECH Act, we were required to implement EHRs, right? The cost is on the individual, and we started seeing a lot of small independent docs folding because they can't bear the cost. When we're looking at moving towards generative AI, we're still in the same infrastructure. We're in the same system where we would be burdened with the cost of adopting, the cost of the risk. And yet the payout, as you mentioned, right, is essentially from the insurance companies. With value-based care, they still decide what metrics we're meeting to make whatever payments they decide at the haircuts that they decide. So my question is, how can we appropriately harness the positive potential of generative AI if we're burdened with all of the cost and the risk in this current system?
Well, the first thing to realize is that unlike something like an EHR, which is, from my perspective, exorbitantly priced due to ability to control the marketplace, generative AI is free if you want the free version. 3.5 is the free version, and it has the 4.0 tools attached to it. And at $20 a month, you're talking about, as they say, it's a latte a week. Most people can afford that in the United States today. So I don't think the cost of application is that great. Now, yes, you need someone to help train patients, and that's why I encourage the large societies. Why should every clinician be trying to develop the learning modules, the tools to be able to train our patients? Why don't the societies produce it? Why don't we produce it out of all the national groups that are there, or all the medical groups that are there, or all the hospitals and all the clinicians who are there? So I don't think that is the difficult part. I think the issue is really going to be around capitation and the cost of capitation. And there's one way to look at it is that capitation is going to be something that is one-sided, which is that, if we don't do whatever we're supposed to do, that we're going to get hurt. I also want to look at the other side, that if we do what we know we can do, and it aligns with our mission and purpose, that keeps people healthier, avoids the complications, avoids the medical errors, that we can really benefit as a consequence of doing that. Now, I want to stress that individual clinicians are not going to be able to accomplish this. It's why you need groups. I was in New York City actually yesterday, and I was speaking to a bunch of entrepreneurial doctors in hospitals. And one of the big systems in the room was Orlando Health. And I said, if Disney is willing to take all of its members, and it has, I think, about 200,000 employees, and put them into your system and have you take full accountability for doing that. Disintegrate the insurer completely, negotiate a price, maybe based upon what's spending today. And now if you can reduce by 30 to 50% all those chronic diseases and their complications, that is a winning formula for everyone, for the patient, for the payer, for the doctor. So I think you're absolutely right in your concern. The other thing that I would say is I think that everything you've just described, it's going to happen if we don't do something differently. It's why I talk about in this subtitle, taking back control of American medicine. Either we're going to be willing to accept the risk, using the tools, collaborating, coordinating in ways that bluntly we have not yet done so far, and the patients will benefit and we will benefit and the payers will benefit, or someone else will do that. And I think that we will be regretful that we didn't take the lead. I encourage, as I say, all of you to purchase ChatGPT MD. All profits go to Doctors Without Borders. I don't make any money off of the books themselves. And it's a wonderful group if you don't know it very well. And I think that if together we can use modern technology to address the growing problems that we face, to improve the health of our nation, to improve the health of our people, that we can once again, and I'll say this to the American audience, there's a foreign audience again, on the line as well, but to the American audience, make American medicine once again the best in the world. Thank you for having me today. Thank you for organizing this program.